Okay. Well, welcome to Physio Forum. April. Don't look out the window, you won't know it's April. It is definitely April. I'm going to share my screen. So my apologies, I won't see any of you now. So if I can just ask somebody, anybody, just to kind of like speak up if hands go up or if people kind of want to make comments. Um, as we go through some of the things I'm going to present today, it would be nice to kind of hear your views on some of the bits that we're going to go through. So please don't sit there quietly. It'd be nice to hear some voices. I'm going to start by sharing. Okay, I'm hoping that's come up for everybody. So we'll see how we go today. Apologies, one of our speakers was unable to make it at last minute, so a little bit of this is thrown together, but we'll see how we go. And as I say, I'm quite hopeful that it'll prompt a few kind of discussions. So today we'll go through a couple of the regional and local updates just to draw to your attention, and then I want to spend some time going through something that myself and Katie and Carrie attended on Tuesday this week, and we also went with Tracy Atwell to something called optioneering, which I have to say is a phrase I've not heard before. Carrie, you said you went to one 2 years ago, so I guess it was a phrase
I'd
you
heard
were
of it,
aware of.
didn't mean I remembered what it was. Yeah.
Yeah, unusual phraseology. I got excited. I thought
Mm.
it was to do with pirates, but I think that's pirateering. I think that's a
Pirateering.
different thing. And what did somebody write on their piece of paper? Orienteering instead of
Orienteering.
optioneering. So clearly it's a newish word. So I wanted to draw your attention to it, and some of the conversations we had, mainly because if you hear in other quarters that these kind of conversations have been going on, I guess I just want everyone to be aware that we've got representation from a Dorset Healthcare perspective and from a physiotherapy perspective at those meetings, because there will be future meetings as well. And it coincided with Rachel Christian Esworth asked me to pull something together the other day about what does physiotherapy look like in Dorset Healthcare, like where's everybody sitting and what we're doing. And I suddenly realised maybe that's something you'd all like to see as well, just to kind of get that flavour of knowing where we're sat and how our workforce looks like. So that's what we're going to go through today. So in terms of some regional updates, I'm going to send all these slides around. So don't feel the need to make any notes, and all the slides have clickable links in them to take you to where you need to go as well. So I'll circulate that at the end. So obviously we know about the HCPC standards. We've kind of had a talk about that before, but there's now quite a helpful kind of webinar page that you can access, and there's kind of upcoming webinar talks in May as well. So if you're unsure about the new standards of proficiency, there's a link, and as I say, you can follow this link with the HCPC, which should be quite helpful to clarify anything. So there's been some work done around looking at drivers of retention, and there's a really good infographic, and I'll show you that on this kind of next page. But effectively, the long-term workforce plan has kind of identified that we need to improve retention as part of expanding our workforce, and we're going to come back to this a little bit when we talk about some of the optioneering. And this idea that we need to renew that focus on retention by improving culture, well-being, and kind of leadership. So they've identified through this infographic kind of 8 drivers that supposedly are going to help, could be used to help support retention in the NHS, and help us kind of with our local policies. So it really kind of focuses on kind of staff experience, that kind of positive workspace experience. And as I say, it's kind of written in amongst a lot of the things like the long-term workforce plan and the NHS retention agenda. So this is what it looks like. So of the 8 drivers, looking at ensuring there's kind of board level ownership and engagement. So, that's why in some of the staff surveys we get asked about how we feel we're able to engage with and influence change, perhaps beyond just the borders of our local services. Looking at that kind of continuous quality improvement approach. I think that's something hopefully we've got quite well embedded here in Dorset Healthcare. You've heard me talk about before the HP huddle, and there's lots of people who will be here at the meeting who continually support that. We have quite a vibrant quality improvement team as well here in Dorset Healthcare, but that's quite good to see. That's one of the factors. Ensuring equality and diversity. I have mentioned before myself, Ruth, I think, has come into the call today. Myself, Ruth Condor, and Rachel Christian Edwards have been embarking on a deep dive qualitative review of the experience of internationally educated physiotherapists in Dorset Healthcare. And I'm pretty sure we started it a year ago. Ruth, was it about a year? I think I saw you come in.
Yes, last year,
Yeah.
around June,
We did the interviews, didn't we, in the summer, and
Yeah.
it's taken us a long time to write those up. And in fact, we were just meeting with Rachel earlier, and there's going to be some really rich learning that comes out of that. And obviously, as an organisation, should be striving to kind of ensure as much diversity in our workforce as possible, because diversity brings new ideas and new experiences. So, again, nice to be that from a physiotherapy perspective, we're kind of already embarking on that journey to improve it. Looking at things like relationships, peer learning, collaboration, um, looking at staff experience, in particular in relation to the NHS People Promise, looking at dedicated resource and capacity. I'm sure that's one that causes a little bit of a cringe to all of us. We know many staff are tired, and we know that we don't have the current clinical capacity sometimes to meet the demand. Looking at this data-driven approach, and finally equipping line managers and having compassionate leadership. I'm just interested at this point, if I can just pause, does anybody have any comments? Does that seem like a helpful infographic? Does it resonate with what you feel is needed from a retention perspective, or are there some key bits missing?
I guess for my thoughts, I think those headings are spot on. They are quite broad brush headings. And I know that there's been so many pockets of work done in Dorset Healthcare recently and over the years to really work and really address as many of those as we can at a practical kind of on the ground level. And so it'd be really helpful to see these regional updates kind of having impact at board level, like say the ownership and the engagement kind of from higher up as well, to kind of help facilitate that. And I think there are work streams going on that are taking that on board as well. So that's just my thoughts.
Thank you, Carrie. Are there any titles that people lean into more than others? Are there ones that you read and you were like, yep, that's a big one?
I think for me, Joel, it's the one around relationships, peer learning and collaboration, and then equipping the line managers and compassionate leadership. Because actually that's something as professionals we can directly impact quite easily. There's some quite quick wins in there that can really help make our staff feel more valued and psychologically safe and just want to remain with us, which I think is really important. And I think that came out of some of the optioneering stuff, which I know we'll come on to later as well. But yeah, it kind of all fits together really, doesn't it?
Thanks, Katie. Just on the note of compassionate leadership, just a reminder, we've got a phenomenal resource in Rachel, and there is the option if people need to have lateral conversations because they're struggling with their line manager, their team. My door's always open. Rachel's absolutely is. There are alternative routes to kind of have discussions, because I think we do know there are examples where that is probably a room for improvement. I guess on that note, looking at these kind of rough headings, is there anything that you think Dorset Healthcare, physio in Dorset Healthcare feels wildly distant from? Are we nowhere near some of these markers?
I'm just going to put it out there. I think the first one, board level ownership and engagement, I think as someone on the ground, I can often feel quite disconnected from what's happening higher up in the trust and kind of understanding kind of why things are happening the way they're happening. I'm not knocking that they're not being made with good intentions or considering all the different elements that board level within the trust needs to consider, or the wider ICS, but I think sometimes the communication of that filtering down to staff, some of the message might get lost, and I think that can impact how people feel about working for the organisation.
Thank you, Katie. And you've
Yeah.
had to work quite hard recently to kind of almost widen your engagement with going to things like DMG meetings, haven't you, and looking at some of those management forums to
and I think
kind of be that voice of a clinician and somebody working in the community.
Yeah, and I think it really does help give you a better understanding of being at those meetings. But actually, we need to look at how that message filters down without having to attend those meetings. Yeah, there is still a bit of a disconnect there.
Sorry, Carrie, were you going to come in?
It was similar, but kind of the opposite end. I wonder about the resource capacity and the data-driven approach. I think those three things all kind of tie in together. And while I think there are areas in Dorset Healthcare that kind of naturally happens, definitely from a learning disability perspective, it's really hard. Rio doesn't collect the data that we need to be able to evidence demand or workload and things like that. And so any methods we've got of like that demand and capacity and demand work, has ended up being quite subjective, and so it's hard for that data to actually have that hitting point to get more of the workforce to help with the demands and work and things that we're doing. And my example was learning disabilities, but we can't be the only ones. I think there are other kind of areas that that's affecting. So we're doing as much as we can with what we've got, but it's really hard to keep working smarter without working harder as well.
And this does, as you said, fits quite nicely with some of the conversation we're having in a minute around optioneering, where there was this push for, you know, the need to think innovatively, because we know resourcing capacity is not meeting demand.
Yeah. Oh, we've got a hand up.
Yeah, I was going to say there's a hand up.
Yeah.
Who owns that hand?
I've got my hand up, Joel. You know it wouldn't take me long.
Is
Liz,
that Liz? Hi, Liz. I can't see
Yeah,
anyone. I'm going off voice. I'm doing quite well so far. Welcome, Liz.
hello. A couple of things actually. So really interesting what you're saying about the board level ownership and engagement. And my experience with that, there's all sorts of different bits and bobs. So if I come at it with my primary care GP Alliance board head on, the board and those people who sit at wherever they are in the trust level are going through a reshuffle at the moment because there is no money. So at the moment, I would be kind and say things are tricky for everybody and no one quite knows what their portfolio is, perhaps. So there is a little bit of that at the moment. From a primary care point of view, there are meetings going on that are deciding massive budgets, and quite often the senior primary care voices aren't even invited to it because they don't think about it. So when allocation of those resources is happening, you're right, the right people need to be in the room to fight for the money. Otherwise, it's only going to go to the acutes. It's only going to go to those people who are in the room. And I think that's something that they're beginning to recognise. Is it consistent? No, absolutely not. But it is being recognised. And I say I'm looking at that from my primary care lens. There's some interesting collaborative work, I think, with the integrated neighbourhood teams coming up, but again, nothing is quite sorted on that. So I think there's a lot of developments rumbling around, which are looking at all of these points, but they're not there and we're not necessarily hearing about it. And when we say about the board level ownership and engagement, I think you have to look at, I think you said the right words there, I think it was Carrie, that it's that filtering down. So the board level might tell the senior management team who are below them, who then pass it down to their managers. And if we look at the stratification of it all, it only takes one level to be so busy they don't get their newsletter out or they don't get that thing for that board level stuff to not come down. So I think it's easy to point at the top, but I think we have to look at all of those levels. And if they're not all working in the right headspace, we're going to find that us at the bottom, we don't hear. And I've been trying to get a newsletter out to my primary care colleagues for 2 weeks now. And by the time I do get round to finishing it and getting it out, it's probably going to be out of date. So I look at some of that with a bit of kindness. It doesn't change the problems that we're having at the front, but I think that you know, there are issues all around. Does that make sense on that one?
Yeah,
But I think the resource and capacity, you know, we've been fighting for rehab for so long that we are so underfunded and so understaffed. And yes, there are recruitment and retention issues, but part of that is because of that understaffing. If everyone's run ragged, why would you stay? So, and having those voices, as you say, at those meetings, I think, you know, we need to be fighting for whatever we can get. Absolutely. So thank you, Katie, for being at those meetings and fighting for us.
I try. I think they just think I'm a bit of a pain sometimes, Liz, but
Yeah.
I'll keep doing it.
That's the best way to be sometimes.
Yeah, we need to add a 9th box in there. Bolshy physios. What I would say is if anybody is hearing your colleagues that are thinking they're leaving, or you themselves are having thoughts that perhaps this isn't for you anymore, one thing that we know that hasn't been going so well in the past and we want to make amends with is recognizing if you're having those or hearing those itchy feet conversations is to come and have a chat to us. So you can reach out to me, you can reach out to Rachel. I've got a wonderful team behind me in terms of the physiotherapy steering group, of which we've got people here today. Have a look on the website if you feel that you'd prefer to speak to somebody because it's more to do with your career development and you can see that they're in your area of specialism. I'm sure any of the steering group, hopefully they're nodding as I speak, would be happy to have those kind of conversations with you. So we recognize it's just important to have those conversations early rather than let it get to the point of I'm just going, is kind of have those conversations.
Joel, we've
Okay.
got another hand up from
Oh,
Nikki
great.
Partridge.
Hi, Nikki.
Yeah. No, it's some things we can't change as well. I'm at Wareham today, despite the background I've got there, because I've driven one of our new recruits to her preceptorship training because the transport networks are just rubbish and she doesn't drive, and a taxi was going to cost 220 quid. So I've offered to do a clinic at Wareham instead because it's too long a drive, because it's an hour to get back to Bridport. We're spread out, and the conversation I had with her in the car, she's been with us, 3-4 months? She's from India. She's already thinking about needing to go to the city just because it's easier to get home. And we've lost somebody else that way in the past because, Bridport is just such a long, long way away from the airports. So you can be as nice as you can, but some things don't change. It's those practicalities, really. So it's not an easy place to live for non-car drivers. So
Thank you, Nikki. And we'll probably touch on this a little bit when we go through the optioneering, because that did come up quite a bit in conversation on Tuesday, is that recognition, because we were talking about system approaches, obviously, to workforce and retention, but kind of recognizing there needed to almost perhaps be a slightly different lens for rural versus conurbation because of the different challenges that brings. I think you've highlighted a really clear one there. And thank you, Nikki. You're a good human. What kind thing to do? How very inspiring for us all. Thank you. Is there any other hands before I move pages?
No more hands.
No. Okay. So, good news, bad news. Southwest AHP Massive is happening again in July. Hopefully, if you want to go, you don't mind jumping in the car and driving to Gloucester, or you have family in Gloucester. Gloucester's very lovely. That was my neck of the woods, the Tri-County area. But there is going to be more details coming soon. So just keep that in mind for July. There's again, remember I'm going to circulate all of these. So there's an event happening again in June for kind of 4 hours, which is a NHS England funded online event, particularly looking at research. I like the very cool way they've kind of gone with surfing the wave. Very clever for the Southwest. That's brilliant. So I will circulate that if that's of any interest to people. Obviously, do reach out. Just remember, we also have a research department here in Dorset Healthcare. So if research is something you want to get involved in more, and in fact, did I see Julia Mardo on the call? Julia, are you with us? No. I thought I saw Julia Mardo. Julia's one of our physiotherapists who's gone to, I believe, work within the research department. So again, if you're thinking of possibly steering that way yourself, maybe it'd be worth, you can go to Julia. If you know Julia, you can come via me and I can put you in contact. I thought this was quite interesting. So this, I don't quite know I struggle to know the link between Florence Nightingale and digital career pathways, but I think it's probably more to do with the Florence Nightingale Foundation that are then offering digital healthcare. But obviously, this is going to be a big future direction for us as AHPs, and therefore it's quite nice to know there is a leadership program out there, that it is something that needs to be funded. It's a 3-day residential program, but looking at, let me come on to this next page, these are kind of things that you'd be able to do on those 3 days. So kind of understanding that approach to leadership within digital transformation, looking at career journeys and opportunities, and embedding digital solutions into practice. So some really quite helpful things there. So if you're that way inclined and you're thinking that this is a direction of travel you'd like to learn more about and be more active within, this is one of the courses that is out there. So I'll get that circulated to everybody. In terms of a couple of local updates, so AECC have just announced this week 2 new masters level units that are going to be delivered over the summer. So identifying, assessing and managing mental health issues and medicines management for healthcare professionals. So there's some links here. They also said they are going to be looking at other kind of courses as well. So if you're looking for some postgraduate education, don't forget the AECC. A little bit of a plea. So there is an innovations event that is going to be happening in it's Dorchester, I believe. Is that the Dorset Museum? Have I written Dorchester? I'm pretty sure that is Dorchester, on the 18th of June. So looking at showcasing any kind of project presentations around service improvement and innovation. So it says that it's a sold out event. I think that is different if you're going to go and present a poster. So again, there's some information there for you to have a look at. The deadline's quite tight because you've got to submit the posters by the end of May. Now, good news. So we have just confirmed that we're going to do a face-to-face event, and you're a world first here, physios, because this isn't out in comms yet. It'll be coming out probably next week. So we've met as AHP leads, and we've said that we really want to do a face-to-face event. We now have funding for that on Monday, the 14th of October. Do not shoot me if you don't work a Monday. I'm sorry, I can't influence. I can't change the days of the month as we spoke about before, and I can't change when AHP day is. So it is going to be Monday the 14th of October, and the event is going to be over in Dorchester, a really lovely place. Judging by the pictures, don't know if anyone knows it, Charlton Down Village Hall, very nice on the pictures. Nice big venue, and we're going to look at running an AM session and a PM session so that staff can hopefully be released in a staggered sort of fashion. That being said, all of these places have fire restrictions, so we will be limited in numbers. And bearing it, we definitely don't have enough places to go across all the HPs in our organisation. So there will be some form of applying for a ticket to go to that event. But for now, if people are able to hold the day or keep that in mind, so Monday the 14th of October, what we're looking for again is kind of either we'll probably be having kind of round table discussions or kind of, I say posters, where really we didn't want it to be a formal event where you had to sit and listen to keynote speakers. We may have some keynote speakers that almost like pop up, so to speak, rather than us sitting in like an auditorium fashion. And the idea really was coming back to networking. We wanted to give everybody the opportunity just to come and meet and greet people that they wouldn't do normally. So we're asking whether you would be able to do a poster. So keep in mind, if you're doing something that involves service improvement or quality improvement, research or audit, something that you've done new ways of working, whether that's how your team works or student placements, something around how you've worked with your team dynamics or wellbeing events, basically anything that we are proud of as AHP. So this is a great opportunity. Please let's not pass on this. It takes a lot of planning to get these things in place. So if you feel you can contribute to some sort of poster roundtable discussion, please come forwards and let me know. Alternative, if it's just something you feel it sounds really great and you want to be part of, just save the date for now and I will circulate more details as they evolve. Right. Can I just ask, were there any questions about any of those regional and local updates before I move on? Okay, so optioneering. So as I say, myself, Carrie, Katie, and Tracy Atwell went from our organisation as physios to a meeting on Tuesday at Westmoors where we had NHS England come and speak about optioneering. What effectively it is recognising the state of play of the population demands and our staffing and trying to come up with a plan to make sure those two ends meet. So some of the challenges are we have a population that is growing. In particular in Dorset, it is growing in a way that means we're going to end up in 15 years' time that Dorset will be the oldest place in the world. So we're going to have quite a challenge in terms of that aging population that are requiring clinical input, but also high levels of care. And rather sadly, and it felt like quite uniquely in Dorset compared to the other southwest regions, we also have our working age population deteriorating. So it's quite an unusual situation for us. Some of the challenges are therefore how we look at sustaining a healthy pipeline of AHPs to obviously meet that demand, how we keep staff, and how we manage that increased demand. And I'm just going to go through a couple of figures here and we'll talk around them. But if hands go up, if someone can just let me know, that'd be great. This is the Southwest. And you can see Dorset, we're down here. I have assumed this is 781,000 people is what that represents, because that feels similar to something I've looked at before. And that's where we sit compared to the other areas of the Southwest. Now, this is what's going to happen in 15 years, is that we're going to see not the highest growth, but we are going to see a 10% increase in our population here in Dorset. But where it gets a bit more of a pickle is if we look at actually those over the age of 65, we are looking at the highest kind of growth, really. So what are we saying? The number of people over 65 in Dorset will increase by 33%, which feels like mind-boggling to me. That seems like such a huge number. So that's in 15 years. Now, at this point, I should point out that's not me saying start making plans to leave the NHS before those 15 years are up, because it's just going to be too difficult. It's actually to have the conversation and say, what are we going to do now to prepare better for the future? Now, this is a horrible graph. Let me just quickly walk you through it. So this current blue line is what's happened with our staffing historically to date, and this orange line is what our staffing is predicted to be. But this is where the demand is and therefore where staffing should be. And you can see that we are effectively in a shortfall of staff, which is why they need to make the plans now to obviously make sure the ship is steering and it doesn't become a crisis in 15 years, that actually we're trying to work actively towards it. Now, they talk about the demand of services, and again, this was kind of a generalized AHP kind of comment here. So the demand for services is likely to increase by 3.5 per year for the next 15 years, which again I thought was quite a significant increase. And for those of us that know teams and services well, and you're watching your referrals coming in and out, that's actually going to be quite a significant hike. But what I would say, this is all based on, so part of that kind of demand on services is based on the same approach as now. And the one thing that we were quite clear on in our discussion is it was all very well saying, well, that's what we provide now, and then you work out 3.5% each year. But I think we were all on the same page as saying what we're doing now isn't exactly anywhere close to a bronze, silver, gold standard of provision, and actually we're lacking capacity for staff at present, which to me therefore means that this gap difference becomes even bigger, because if we were taking into account things like right to rehab and staffing services appropriately, then actually there would be a bigger gap. Can I just pause at that point and ask any of the ladies who are in the room on Tuesday, is there anything else that I perhaps missed around that would be worth bringing in at this point?
I guess only to say that if you look at this graph starts in 2020, but actually there were conversations kind of leading up to this point. So although it feels very scary to see this dramatic increase, it's knowing that we have had this increase for a while as well, and we've dealt with these challenges historically. So I think that's where it's part of an ongoing conversation. So like Joel mentioned, that was part of the work a few years ago, which I definitely have been, but I'm not convinced it was the last one. I think it might have been the one before, where we're always constantly looking ahead to the future. What direction are our populations going in? How are we working, and how do we best change to meet those, to adapt to meet those needs in the future? So it's not as terrifying as it looks, but it does show that we're going to keep having these increases. We're going to have to keep changing, keep evolving to keep up with the demand on our services. Yeah.
Thank you. Thanks, Carrie. Okay, so we did talk within that. There is kind of a bit of an idea of how that gap is closed. So a big part of it is to sustain a healthy pipeline of staff graduating, staff coming into physiotherapy roles, whether that is through any of these routes. So either as undergraduates, apprenticeship programs, return to practice staff, international or out of region recruitment. I can't think of the phrase they kept using for out of region. It was something
Wider
like
labour market.
is it world labour
That was
market
it.
or
It's the
something? It was
wider labour market.
wider
now.
labour
Yeah,
market.
WDL.
Oh yeah.
We sounded
Or else.
incredibly big, and it was almost, to me, I was, yes, but what they were almost talking about is just anything outside the borders of Dorset,
Yeah.
which was interesting because I think, was it Hampshire and Isle of Wight was one of our biggest catchments of where for physiotherapy in the system is where we tend to. It was hard to tell. They moved between AHPs and physios quite a lot, didn't they, with their graphs? And it was hard to know whether we were drilled down into physio at that point or AHPs.
Yeah, I think it's important to recognise that it was a pan-Dorset approach, because for Dorset Healthcare, certainly recently from my experience, we've recruited a lot from the acutes, especially the stresses and pressures that COVID added onto acute therapy meant that we have benefited in the community more from people wanting to move over. So this piece of work is looking like, essentially that's just moving holes in the system rather than helping to resolve them. So we're looking at how do we move people in from other areas.
And I think it was quite a surprise how many people were on the predicted graph of being that kind of out of region recruitment. It did suggest quite a bit of movement into Dorset, which was reassuring. And I guess, Jenny, I was thinking of our home team. We've recently taken 2 people, not very recently, but from London. There is, and I wonder how much of the pandemic kind of has made people reevaluate where they're working and what they want. And as you say, Carrie, I've noted again within teams, as you write, that draw from the acutes, where the acute work has now evolved to be something that perhaps people don't recognise or resonate with, and therefore coming to the community. So yeah, sorry, go on.
I think also, Joel, though, recognising in that, although we've seen some movement to the community in some areas, as Nikki was saying earlier, the rurality of some of our other populations in Dorset. I know, 46 of Dorset's population live in rural spaces. Like, that's a massive amount, and actually that doesn't make those areas as attractive to work because of transport links, there not being a major town. That it does make it harder. So I think we've definitely seen the benefit in some areas, but not across the county.
Thank you. Yeah. The other ways to close the gap: retain staff. And the kind of other big key they were talking about was innovation. So that did capture things like digital. It talked quite a bit about integration, and staff potentially working in slightly different ways. I found some of that conversation a bit challenging. The idea of, perhaps placing more responsibility on our support staff, albeit with training and competencies, etc. But that appears to be a bit of a move across not just AHPs. They mentioned about potentially revisiting how a GP role may look. And we know already we have obviously FCPs, we have ACPs that all take away from perhaps what original GPs in primary care were providing. So again, it's not like we're at a standstill point. It's almost about trying to identify where these have worked well and where next needs to be looked at. Physiotherapy is probably I keep wanting to say strongest, but I'm doing that competitive thing again, aren't I? We're in the healthiest position. That's a better word. We're in the healthiest position in terms of our ability to meet our where our staffing is and where it needs to meet compared to other AHPs, OTs in particular. And that we had some interesting discussions about whether that will lead to, as part of innovation, is a bit of a redefining of, if we've got physiotherapists, would we need to look at roles that were being provided by occupational therapists as being an advancement of our skills to move in that direction. In a similar fashion, there was a conversation talking about osteopaths, and actually the involvement of osteopaths to take, to alleviate some of the MSK style pressures being faced by physiotherapists. So, and I guess I'm talking so vaguely is because that's kind of how the conversation was. It really is at the moment just ideas kind of sharing. But the concept of optioneering is NHS England to go back to the system and say, this is something that would be a useful strategy for physiotherapy to consider for the next 15 years, which I found quite hard. I don't know about the ladies in the room. Time that, considering optioneering happened a couple of years ago and it's going to probably happen in a few years again, it feels like there's various points along the next 15 years to talk and make changes. It wasn't as though there needed to be a plan now
No.
that sustains us for 15 years. What did you all take from that?
I felt very challenged by it because I think Laura Whitehorn, who was there from HR, made a very good point that actually we were trying to build a strategy around workforce without actually knowing what our services are going to need to deliver in the next 12 months, because we know there's a lot of change going on in terms of how, especially for community services for Dorset Healthcare, how teams are being restructured, how things are going to be delivered, the introduction of neighbourhood teams working at place. I think there's a lot of stuff happening that will change what the demand is for physio, but also the recognition that actually the strategy that would work for the acutes won't necessarily work for the community teams. So actually to come up with a workforce plan for physiotherapy across the board, considering how diverse a profession we are, was a really difficult thing to try and hammer out in, what was it, 6 hours?
Yeah. Or less if you got stuck in the queue trying to get in the beginning.
Liz has got a hand up as well, Joel.
Hello.
Hello.
I wasn't in the room. I think I'm now thinking I missed a trick. I don't know if anyone from primary care was there. So that's an interesting one. So this again comes back to primary care. Don't get in. We're not even thought of part of the conversation. So that's an interesting one, which I'm going to have to reflect on. I think I understand some of the challenging nature of this. I think in MSK we had some of these challenging thoughts a few years ago. So we've had a little bit more time to get our heads around anybody with the right knowledge, skills and attributes. And it shouldn't matter your professional background if you have the skills to do the job. And if we look at the sort of senior leadership AHP space, how we've been fighting to say, well, why does it have to be a nurse to do that job? Why does it have to be so and so? And I think if we bring that down to all levels, we should be looking at our workforce and finding who has the skills that can match that identified need. And it shouldn't matter where they come from. I think we can be quite professionally challenged by that. Absolutely. And I think it's right that we should, because and some of that might come down to what is our core identity. But in the MSK space, there are some amazing osteopaths out there, and in fact, they are part of the HCPC. The college is aligned, so there's been some challenges in just getting funding to pay osteopaths. Certainly in primary care, they weren't part of the R's thing. And I just thought I'd say that really, that we should welcome some of these changes and support these other professions or other people. And I look at it as enriching the care that patients get, as long as there's governance in place, as long as they've got the knowledge, skills and attributes. And that's the tricky bit. Sorry.
And that's all right, Liz. That's what Laura was saying on Tuesday, actually, was that actually trying to plan a workforce supply for physiotherapy as a profession is really difficult, when actually we should be looking at what are the knowledge, skills and attributes we need to deliver the services, and
Yeah.
then building what our workforce strategy is across the board around that, rather than it being profession specific. And she raised some really good points, and I think, I'm not really sure Simon had an answer for her when she challenged him on that on the day, but it definitely made us all think a little bit more about that. And you're right, we should be welcoming people to work alongside us who have this knowledge and skills to be able to fill some of those roles that traditionally we can't fill how we have been.
Yeah. The other thing I would say is I think this level of conversation might have been more beneficial for different professions where there is a profession specific problem. So I think that kind of links in with what Joel was saying about physiotherapy generally is in a stronger position than we have been for quite a while in terms of recruitment. Absolutely, there are real challenges in rural areas and in specific posts where we're looking for people with specific levels of experience and they just don't exist, or we're not getting the applicants. But generally, looking at physiotherapy from that overarching view, we're in a very different position now than where we were when we were having to put adverts out for 10, 12 times and not getting any applicants, or all of the applicants were getting snapped up by the acutes. And so we weren't getting people turning up to interview. There's definitely still pockets of that happening, but generally things have changed from where they were. And so I think that's where this conversation, looking 15 years ahead, we know our population's needs are going to grow in this way generally. Where are we in terms of our own strategies for recruitment and retention and meeting that gap? But yeah, in terms of the specifics, there are definitely specific conversations we need to have in terms of where ACP roles are fitting in. We've got some here, we've not got some over there. What does that look like? Why is that okay? And all of those conversations need to be had, but in a lot more detail than we're able to go into in this kind of optioneering project. And I think that's also where it's really helpful, although we've got this 15-year plan, to keep having these conversations every couple of years, because actually even looking back from where we were 2 years ago or 4 years ago, before the apprenticeships were up and running, we had all these ideas of brilliant, this will really help with our recruitment because there'll be loads of newly qualified physios coming through the apprenticeship route. There'll be young people going straight from school, from college into these apprenticeships and coming out. And actually what we're generally seeing is that it's the support worker workforce that are going through these apprenticeships and coming out at that level, which is great. But then that also affects our support worker workforce that we're already existing in that role. And having those conversations and reviewing them gives us chance to tweak, oh, we thought this might happen, actually that's happened. So it's not just that's it for the next 15 years. It is an ongoing conversation, but I think there is probably bits of work to do around the specific details affecting the pockets where we are still struggling.
Yeah, thank you, Carrie. Are there any other hands up, may I ask?
No.
Not at the moment, no.
What I thought was quite interesting, and maybe I hope I've got my head around this, and please, lady, jump in and correct me if I'm wrong, but they were saying this is our last good opportunity to recruit inspire a lot of 18-year-olds en masse to go into undergraduate programs such as physiotherapy, because of the way that our generations have worked post-war. So with the baby boomers, obviously when they got to a certain age group, they were having children, and then when they got to a certain age group, they were having children. But because enough time has now gone past, that there's much more merging of when people are having children. It's not working on I can't remember what they said, it was like a 20-something year cycle, was it, or something, you know, that there's this peak in 18-year-olds, and then it goes quiet, and then another peak in 18-year-olds, and so on and so forth. Is that how you understood it when it was told, or have I Joelified it?
No, yeah, that's right.
Yeah. Which I thought was quite interesting. But I guess the difference being, if there's not this peak of 18-year-olds, you'd hope there's more sustained numbers of 18-year-olds kind of going through. And the apprenticeships were an interesting discussion, because we've obviously done well. Dorset Healthcare kind of got 4, technically 5, but one's not started yet going through. And it'll be interesting to know, there are already talks from our colleagues in Dorset County saying they feel they've saturated their support workforce to put them through for OT and physiotherapy apprentices. And, you know, it will be interesting to know and we did try to factor that in when we were looking at some of the forecasting to say that it might not be something that can be consistently high each year. In fact, I think the system average was it one. They worked out the average of one physiotherapy apprentice a year. It might have gone up to two when we had kind of those conversations. But there were some really careful thoughts about where people would come through. But we got to the point in the discussion where we closed the gap so closely in 5 years that actually we felt it wasn't worth thinking about what would then happen for the next 10 because it was already so close, and actually if we're going to come back to another discussion, and I guess it's that reassurance of, as you've probably heard, physiotherapy is in a stronger position, but it just needs that continual just tweaking just to kind of steer the ship and make sure we're still on course. Okay, so if we talk about physiotherapy students, I thought this was quite interesting. So as a whole system, we're recruiting 9 whole-time equivalent physiotherapy band 5s a year. But we need to increase that to 38 a year to meet the demand. So that's quite a significant change. They didn't talk particularly about where the budget elements of this would come from. It was far more theoretical, and I got the impression that it was because if through optioneering you can show, well, that's what you need the 38, it's almost going back to the system and saying that's where we need money. We need new band 5 positions to make sure we can bring in 38 a year to meet that demand. Now, some of that is people will vacate out of band 5 posts, so it's not necessarily you need to create an extra X number of posts because there's a little bit of levers going on and people filling. But actually we still need this higher requirement of band 5s to go through. I thought this again was quite interesting. So I'll be the first to put my hand up, and I think I've said this in conversations to BU and AECC as well, that I've had my frustrations that as a local workforce we're putting on a lot of placements and then their undergraduates are moving out of area, and therefore as staff we're doing a lot to train them and give them that brilliant experience and that Dorset Healthcare exposure, and then they're going. Technically, the statistics would say that's not the case. So of our physiotherapy undergraduates, 76% of them are coming from the south of England. And those are the different splits between the southwest and the southeast. So actually, we are getting a lot of students who have gone to university in the south of England who are then coming into Dorset for their posts. And it really was a north-south divide. The moment we went out the south of England, the numbers were incredibly low, like 1%, 2% of anything north of the south of England, really. So that felt reassuring to know that potentially there is a stronger link between what we're offering and them staying. But even with that, talking about obviously the need to increase the physios band 5 positions, and part of that is obviously to get more students through to be able to meet that, we are looking at quite a sizable hike in placements. And we were saying that it's really difficult because a lot of our work has been governed by clinical need and markers, and we've kind of diluted the learning element of a workforce. We've talked before that realistically we should be in a position where we have students continually, that one leaves, another comes into their place, that it's a whole team approach to providing the placements. But we know it doesn't work in that way because we just don't have the clinical capacity to be able to do it. And if we do that, we're not going to be able to see the patients that we see. And it's almost like we've got into this quagmire of we've become so focused on the targets that are so clinically driven. It's meant that we're not giving that rich learning experience. Whereas actually, if you look at this as a crisis, what you need to do is flip it on its head and go, well, actually, if we need to keep churning out therapists, we need to be offering learning experiences on a greater volume and consistency. And if the waiting lists go up, then that should be dealt with in a different approach, not the sacrifice of learning. Can I sense check? Is that what you guys took from that as well?
Yeah, definitely. And there was a lot of discussion. There was a lot of discussion about the challenge of supporting more students on placement. There was bits of conversation about the different models and the other work that's going on elsewhere in the trust to look at the support that the trust gives around students on placement and different styles, and kind of the logistics of organising different types of placements. I think there's definitely scope to introduce more support and around those different models that would help manage or reduce some of the burden, I guess, on the PPEs when we've got students on placement. But it's a real challenge, like trying to increase placements in teams where we are regularly taking students. It's not going to be an easy fix. So it's the challenge.
Yeah, thanks, Gary. Okay, so these are just a few things. I just wanted to throw a few kind of things that were thrown at us in terms of facts, which I thought were quite interesting. So we're sitting at just over 1,300 whole-time equivalent AHPs in Dorset. Our workforce actually grew by quite a lot. That was almost double what it would usually be. So we have had a growth in an increase in the growth of our workforce. I thought this is quite fascinating. The average age of a joiner to the system, AHP to the system, is 32, and the average age of the leaver is 41. So they were kind of showing that we're not having a particularly potentially long stay in the system. The average age of AHPs is 41, and 14% of our workforce are over 55. And yeah, the average length of service for people who are leaving is 8 years, with resignation being the main reason for leaving. It was really tricky. I mean, this has come up a few times in other conversations as well, but we don't really have a really good understanding of why people are going. The drop down choices and the options people pick aren't fantastic. To me, I would assume that resignation would be a big reason for leaving, but unfortunately, they weren't able to drill down into that. So if we have a look at, this is the whole system here, and these are obviously the different HPs, but I've highlighted for physiotherapy. So just to give you some comparison, this is whole-time equivalents. So Dorset County has 55 whole-time equivalents. This is of January, and it's going to differ from what I show you in a minute. Our organisation, 141, go Dorset Healthcare, and UHD just a little bit more. So I don't know if that's as expected for people, whether that's a surprise at all. Okay, so if we have a look at where our mix works in terms of, this is all AHPs, what you can see is what they've termed a bit like a Christmas tree model. So we've got, you know, the band fives kind of here, we've got band sixes, which is kind of the wider element, slightly narrower with the sevens and the eights. So what I've done is have a bit of a look at where we sit in Dorset Healthcare. So our band 5 staff at the moment make up 11% of kind of our staffing. Our band 6 takes up a whopping nearly 60%, band 7 about 25%, and a smaller number obviously for the band 8 positions. So if we compare that to what they were just showing there, so Dorset Healthcare being in blue, you can see we're offering almost half the amount of band 5 positions compared to the rest of the system. We also have quite a significant more band 6s compared to the system, and then less band 7 and band 8s. I just wondered, I have an interpretation of that graph, but does anyone else want to hazard a go at what it means to you?
Means there's less opportunity for progression, so it's less attractive to new staff, potentially, maybe.
Yeah, with the fewer band 7s and 8s. Yeah,
I'm doing well. I'm doing well. My voices today.
You
See you. Hi, Maxine.
Do you know all the
You've heard
physios
my
in the
voice
trust? Like,
enough over the
I know you
years,
all by your
haven't you?
voices. You know, if we meet in person, it's over. But if I can hear your voice, it's okay. Yeah, Maxine, you're spot on. That's how I read it as too. Anyone else get similar vibe on that?
Yeah, the other thing is that I think with having fewer band 5s in the community services, I think makes sense. But we're sometimes seen as jack of all trades but not master of none, but we're not. We're community specialists, and it's harder to have band 5s well supported in community specialist posts, I think. So I think that's also part of the balance there.
We'll come on to I've done a bit of a breakdown of where we sit with our
Okay.
bandings. What I would say with the band 8 is you've got to remember a lot of band 8 positions do have managerial components to them. And I think there is the other conversation that came out was there is a more defined clinical progression pathway potentially in MSK services compared to acute therapy or community therapy. There's also not brilliant leadership pathways, but they do seem to be more obtainable within the acute organisation where they've got those
Mm.
hierarchies and those opportunities. So the fact that we're down on the 8s is probably a bit reflective of we don't have a lot of band 8 managers yet, and actually a lot of those band 8 positions are made up by certainly by MSK clinicians in our organisation.
I just wanted to come back to the band 5 bit as well, Joel, if that's all right, just because I think you're right, Carrie. I think we are community specialists, and I think that's really important. And there's a massive lone working risk to a lot of our staff in the community. But actually, a lot of teams have really embraced that band 4 assistant practitioner role within their services. And I would argue if we feel we've got enough support to train and to use band 4s, why are we saying we can't do it for band 5s and give newly qualified physios a chance to progress through community as a career pathway? Like, we really need to think carefully about that, because actually we've got a gap there.
Yeah.
And we
Yeah,
should be
definitely.
encouraging more band 5s to look at community as a career option.
Yeah, I totally agree. It's about making sure we've got the right support for band 5s in those environments and teams and communities. But yeah,
I'm just aware of time. Can somebody tell me what the time is? I can only see my wall clock and I'm not sure
1
I'm
minute
seeing
to
it.
1.
Okay, right. I'll fly through these next slides. Bear with me. We're going to go through these in a minute. So I will send these round so you will be able to process them at a slower speed. So this is our breakdown of our staffing. So we are 176 physios. We are more if you count in the bank, but some people are on bank and on contract, which makes it quite, none of this information is easy for me to process the way it comes in the Excel document. So I have done my best here. But yeah, so we're looking at about 127 whole-time equivalents of physios, and you can see the different breakdown there in terms of we are that Christmas tree of 99 at band 6, slightly smaller stump at 15 for the band 5s, and then obviously it's shortening in as we go on up. So where are our positions? So at the moment we do have band 5 positions in all of these areas. So we've got ICRT, community therapy, LD and MSK. When it comes to our band 6 positions, and although you must remember the MSK kind of bits looks a lot, but if we were to then add up community, as a counter, it would kind of be far more balanced. So please don't read into it in that way. But that's where a lot of our band 6 positions are. A continuation of our band 6 positions, mainly looking at some of the ICRTs. I don't know if any of this will be a shock or surprise or just a confirmation nod for some of you. Other band 6 positions here. So we're in my home team there, the community therapy team, CBEX, PICS, Gold in the inpatient team. Where our band 7 positions are sitting. And, as I say, I can only go off what I've been given. It might well be things have changed from the start of this month to now. Some more of our band 7 positions sitting in these kind of key areas. And then our band 8 positions. So as I say, we mentioned about Dorset MSK, so that kind of advanced practitioner route. Our physiotherapy consultants, not ours, they're system wide, it's just we're hosting them. I didn't know whether that was a similar situation with the spinal consultant or whether they were purely under Dorset Healthcare. And a couple of team lead roles and the professional lead role. But we've also got therapists that I didn't count from a clinical perspective, but are in some really interesting kind of areas where they've taken kind of different kind of career moves. So research practitioners, discharge and flow, D2A, Rocky Health, ACPs. That was really good to see that we're getting everywhere as physios, aren't we? That's brilliant. Okay, age. Again, I'm just going to fly through this. So this basically is showing where we sit. Dorset Healthcare is not particularly different than a lot of the organisations. We do have a slightly higher 55 to 69 group compared to the other organisations. How we fare as different professions and physiotherapy here, there's nothing, we're very middle of the ground really with our spread. No kind of peaks on that one. This was quite interesting. So this is the amount of time being in the organisation, and actually we're DHU, Dorset Healthcare University, I guess Foundation Trust is where they were going with that. So we are having people be in the organisation for longer. It's a shame they didn't put the percentages on here, but if we look at this kind of group of people between 10 and 20 years, we are we have got staff with that level of experience, which is great. And then looking at physiotherapy, again, we are literally kind of split amongst that, so nothing of excitement there. But if we look at our organisation, So we're looking at people who are in that kind of 0 to 5 year kind of category. So 55% of our staff are up to 5 years. We've then got 6 to 10, so that's kind of that 25%. Staff that have been with us 11 to 15 years, 8%, 16 to 20 years, 10%, and 20 year plus. So I think we've got an opportunity here to potentially, understand that more and understand what has retained staff, what has kept them not only particularly in physiotherapy, but for our benefit has kept them within Dorset Healthcare. So just a couple of conclusions. So obviously there's going to be more work to be done around optioneering. Dorset itself does have this unique age problem that we've spoken about. It really highlights that importance of retention, innovation, and maintaining the pipeline. Physiotherapy relies heavily on undergraduate programs, which is great as long as that doesn't change in any way, but we are going to have to look at the need of increasing placements and also the need to kind of increase band 5 recruitment. So a reminder that actually a whopping 76% of our undergraduates are coming from the south of England. So there was talk about whether there needs to be more targeted work. We are working with Winchester and occasionally Southampton, but does that need to be amplified, knowing that we are taking a lot of their graduates and therefore improving that experience at Dorset Healthcare could be quite beneficial. The clear career progression does seem to be more clinically defined in MSK services. That's an area of learning and see how that can be changed, and that improved need for acute and community settings in terms of looking at career progression. And I'll stop there. I'm sorry I had to rush through that last bit. Can I just ask, are there any questions at all from the room? Was it helpful to go through that? It's not something we've done
scary.
before.
Yeah, really helpful.
Really helpful, Joel. Thank you. Yeah.
Yeah, I want to have a chance to properly look at those stats when you've got time to process it.
Yeah,
Yeah.
I will send it all
It's
around
really
to you.
interesting.
So
Yeah,
do have a look at it.
Looking at those slides, and I've just emailed Emma Halliwell over in Workforce to say, looking at these and your predictions, they're less than they should be because primary care are not involved in any of that. Primary care stats are very unreliable. We know that. You've got 78 businesses all doing their own thing, so it's really hard to get data out. But the long-term workforce plan is for one first contact practitioner MSK per GP practice by 2032. That's not long away. So if we've got 78 practices with over 105 premises, that's 78 FCPs, which we don't have at the moment. So, when I look at this data, I think, and that's not even including wanting to get OTs and dietitians and speech and language into primary care. So, sorry. It's even a bit more gloomy because we still need to train them. We still want people to work in Dorset. They've still got to come through as band 5. And how do we work together as a system and get out of that silo working and share placements and share learning? This is the thing.
Exactly it. Yeah.
For me, it's we as Dorset Healthcare, we have some unique opportunities to provide learning for a well-rounded clinician, and the acutes have specialities that we can't access, but they don't share the learning. So if someone's giving an in-service training on something management, why is it only their trust that get that training? And I think that's what we need to look at, is how do we share these educational opportunities? Sorry, soapbox.
No, really good points. Thank you, Liz.
Good one.
Okay, well, thank you all for your time today. I'll close that and we'll, as I say, circulate those slides around. And if you have any queries or questions, as always, come and have a chat to me. That's great. Enjoy the rest of your
Thanks,
afternoons.
everyone. Thanks, Joel. Take care.
Okay,
Bye.
all the best. Bye now.
Bye.